All right, great. Thank you all for coming, and thank you, professors, for giving you extra credit for coming. I appreciate it. At the front row, I have a lot of my coworkers who work at the Department of Commerce, and I got some of my family members in the audience. So I'll tell you a little bit about myself. I'm an actuary. I've been an actuary since I graduated from college 23 years ago. I started out as a pension actuary. I spent 10 years in pension, and then I started terminating so many pension plans, I started to get worried about my own retiring as a pension actuary. I'm not discouraging you from being a pension actuary, but I'll just say I was so busy terminating plans that I started to get worried, told a recruiter I'd be willing to switch fields. I was kind of getting bored, and so I switched to health about 13 years ago. Worked for Blue Cross Blue Shield for 8 years. Working, can you hear me? Can you all hear me? Working as the director of group. So I worked on rating health insurance plans. And then after that, I went to the Society of Actuaries. I worked for the Society of Actuaries for 2 years, working on their continuing education events. And then I switched to the Department of Commerce about 2.5 years ago. So I work for the state of Minnesota. And to give you a perspective of health insurance and how it works, or property and casualty insurance or life insurance, how it works is the states do a lot of the regulation of rates and legal language of the contracts. And so, you know, we like to say we're the people that actually read the fine print before you signed up for a life insurance policy or a health insurance policy. And so the state takes a huge role in the regulation of all kinds of products. And when I switched to the state, anything in the health arena kind of came under my rate work. So individual market, small group market, large employer market, disability insurance, long-term care insurance, other kinds of contracts that you've never heard of. So that's what I do, and I work on rates. So some of you, when you graduate and you work for an insurer, and you have to do a filing, I'm the person on the other side one day that you'll be like, dang, you know. So that's who I am. You might also come across some of my work when you take a later actuarial exam if you choose to be an actuary. One of the big textbooks in health insurance I work on for the curricula. So I still do a lot of volunteering for the Society of Actuaries. So today I named this presentation an overview of the individual health insurance market. And I could have named this presentation an overview of Minnesota's experience with Obamacare. But if I had named that, I think there'd be we'd fill the room and there'd be a whole bunch of reporters. And I decided, no, let's name it something like it's a very innocent name, like, let's talk about Minnesota's experience with the health insurance market. So we're going to be talking about Obamacare today. We're going to talk about what happened. It's a big issue. I don't know if you were watching the news. It's pretty big. So we'll talk about it, and we'll talk about what Minnesota's doing about it. So this is kind of a funny little comic strip when the Affordable Care Act came out. It's like, what are you reading, War and Peace? No, I'm reading the health care bill. So it was 2,000 pages. The Affordable Care Act, and what's interesting about that is there's been like hundreds of thousands of pages since then. And so basically, usually when a law is passed, it's very short, and it gives like the intent and the strategy of a law, but it leaves it up to regulators to kind of figure out the details, and it's not thousands and thousands of pages. But the Affordable Care Act was different because it was kind of like a regulation. And it passed as a long regulation. And a lot of the regulations didn't work, and so they've changed since they were originally written. So let's start with like health insurance and getting a feel for it. Where do people get their health insurance from? And the United States is like really weird. So a lot of people, probably a lot of your parents, are getting their health insurance from a self-insured employer. So about 37% of Minnesotans, 38%, are getting their health insurance from an employer who offers it, And the employer sets the terms of the contract, and the employer takes all the financial risk on the insurance. Does that make sense? So we call it self-insurance. And then right here is the large employer insured market. So these are an insurance company files a policy with us at the state. We review the policy, and then the insurance company offers it to large employers. And so that's about 12.6% of the market. So almost half the people get their health insurance from a large employer. Does that make sense? Then there's this bucket right here. This is small groups. So this is employers that are less than 50 people. It's about 5% of Minnesota's market. And the reason why it's in a class of its own is because years and years ago, if you were a small employer and you had an unhealthy employee, the insurer wouldn't really write your whole group. They'd say, look, you got a hemophiliac and we can't afford you, and so they would reject them. And so a law passed about 20 or 30 years ago to say, no, all small employers have the right to get a quote on health insurance on anybody who's selling in the state. And then it said, and the rates are going to be no more than 25% less than the average or 25% higher than the average. So they kind of constrained how much they could charge a small employer for health insurance. So that's why it's a separate group. It's a separate kind of policy with separate rights and separate rating rules. And then there's the individual market, and that's where a lot of the brouhaha is over the Affordable Care Act. Because what happened in the individual market prior to 2014 was if you didn't have a job, let's just say you were self-employed, maybe you're a daycare provider, you're divorced, you decided, I got to watch my kids, I might as well watch some other people's kids, I'm going to try to get health insurance directly from an insurer. We call that the individual market. And there's a lot of farmers in there, there's a lot of daycare providers, there's a lot of entrepreneurs in there. A lot of people taking a huge risk on themselves are in there. And in the past, if you bought your insurance from this individual market, they could reject you. So they'd ask you for everything about you. They'd ask about, like, what diseases you have. What diseases does your mom have? What diseases does your dad have? They would reject about 20 to 30% of people, especially as you were older. Because you're more likely to have a condition the older you are. And so they would reject about 20 or 30% of people, and they therefore had a very low price as well because there was really healthy people left in the pool. So it was really affordable health insurance for those who got to get health insurance. Does that make sense? Okay, so it was really affordable. And then right here is TRICARE. That's another word for the federal employees. So, your Army, your military, your FBI agents, your CIA, your Congress workers and their staff, they're all on TRICARE. Then there's Medicare, and that's, everybody knows what Medicare is. It's probably what your grandparents are on or your great-grandparents are on, right? So, and then there's Minnesota Care and medical assistance. And medical assistance in Minnesota Care, medical assistance is Medicaid, so it's for our low-income people that need health insurance. They qualify based on their income. And Minnesota Care is our extension. We've always been a great state for trying to get more people covered. And so Minnesota Care is a special extension of Medicaid. It existed before the Affordable Care Act. It existed after. But it's another 2% of the population who get Medicaid-like benefits administered by the Department of Health and Human Services in Minnesota. And then you have the uninsured. And 4.3% right now of Minnesotans are uninsured. All right, so that's an overview of where people are getting their health insurance from. So what did the Affordable Care Act do to each of these markets? It kind of changed everything. It changed all the markets, some more than others. For the Medicare people, it's really great stuff. Before the Affordable Care Act, Medicare didn't really have a preventive visit. They had like a one visit when you first were age 65 and you first got into Medicare. You had something called a Welcome to Medicare visit. And but when the Affordable Care Act passed, they said, they need a preventive visit. people on Medicare need a preventive visit as well, and so they can now have annual physicals with 100% coverage on Medicare. So that's an extension of benefits. The other thing Obamacare did was Obama negotiated very, very diligently with brand name pharmaceutical manufacturers and achieved a 50% brand drug discount for the whole Medicare program. And so that's a really, really good savings that affected the whole country. So the other thing it did was it closed this, what we call this donut hole, which was this design that had been originally created when drugs hadn't been covered until the Bush administration. When George Bush, second George Bush, the younger George Bush, was president, he actually added pharmacy. Pharmacy had not been covered under Medicare until 2006. So it was a pretty new program to have pharmacy. But when they designed it to give no coverage in the middle. So they called it like a donut hole because there was no coverage. There was coverage at the beginning of like your costs, and then there was this big, dark, like $2,000 that you could absorb in costs in the middle. And then if you had costs over like $5,000, you got really good coverage. And so they called it the donut hole. And what the Affordable Care Act did was fill in that donut hole by 2020 so that it's a 25% coinsurance. So the Medicare person has to pay 25%. The Medicare program pays 75%. But it gradually went from that level, this missing coverage, to filling in that $2,000 by 2020. Okay? It also started linking payments to doctors to their and health plans to quality outcomes. So instead of Medicare's big issue is the reason why it's so unaffordable is because it pays for every service. It's just basically you have a service that pays for it. You have a service that pays for it. So what they're trying to do now with Medicare is put more risk both on the insurer and the provider for proving that they're not just utilizing services of health services, that there's a clear reason for it, and there's a clear quality outcome. So that's just a brief overview of what happened to Medicare. Pretty much all good, right? Medicaid is also really profound. Our state had been a state that tried to actively expand benefits to low-income workers for years. But a lot of states are not like that, especially in the South. So Alabama, Mississippi, Louisiana had some of the worst uninsured rates as a state, but mostly because they gave bare bones Medicaid assistance to everybody. So what the Affordable Care Act did was expand. It was easy for people to get Medicaid coverage if they had kids, but it was very hard for an adult that's low income without kids to get health insurance. So what it did was it expanded coverage to childless adults to a federal poverty level of 133% of the federal poverty level. The federal poverty level is something around like $14,000 a year. So if you do the math, you could kind of guess, it's like 17, 18, 19,000. It gets inflated every year. So, and it basically paid for that expanded population. It paid at first 100%. The federal government paid 100% of the expanded population's cost, and then it ratcheted down to about 90%. And so the federal government is paying for a large share of this expanded population. So it's all good, and it really expanded it really helped the uninsured rates in every state. This was one of the big U.S. Supreme Court decisions, though. A lot of states said, I don't believe it. I don't want to accept this. The feds are gonna, you're gonna take away that 90% and you'll make it 50 later, and then the state's gonna be left holding the bag. And so a lot of states were really worried about it. And so one of the big Supreme Court decisions was the original Affordable Care Act was written that if you don't expand, you will get less money for your original Medicaid population. And the Supreme Court said, no, that's coercive. You already kind of made that Medicaid promise on the old population. You can't coerce these states to expand their Medicaid. So a lot of states still haven't expanded their legislatures haven't expanded the Medicaid access, but our state was already there. So like our state already had this expanded access. So it's kind of interesting, but we got more money for those people. So it's really helped our state budget. All right. So self-insured employers, what happened to them? That's a big bucket. Everybody got 100% prevention. You probably all know this one. This is like the most popular one. Like you could stay on your parents' plan until you're age 26. Do you guys know that one? Yeah, everybody seems to know that one, and they're like, yeah. And that's like one of the most popular things about the Affordable Care Act that people don't necessarily appreciate. It's like, yeah, I'm going to stay on my parents' plan until forever, right? So, and then it prohibited pre-existing condition exclusions. So some employers could write a policy where they said, if you have to tell us about a condition you have and we won't pay for that particular condition, we'll cover you, but not for the thing that you actually need the most. So that's a pre-existing condition exclusion. And so it prohibited pre-existing condition exclusions. It removed annual and lifetime limits. So a lot of plans were written with a $5 million limit. And you think to yourself, well, who would use a $5 million? There's somebody out there that's going to use $5 million. And what would happen was that their employer plan would say, sorry, you got to $5 million. And so we're going to move you over to the state. We're not going to cover you anymore. And so, find a new job, or, they didn't say find a new job, but you might need to find a new job if you used up $5 million health insurance. There's grandfather plan exceptions. So if your plan was like stated to be frozen in 2010, you could keep it as you had it, but you had to do a lot of legal work to keep it. And then the Affordable Care Act put a lot of taxes on employers for not offering health insurance, especially large employers. So if you didn't offer health insurance, you get a penalty. If your person happens to come and get a federal subsidy, you get even more of a penalty. And then this is one of the most, this Cadillac tax, this is one of the most controversial Affordable Care Act provisions. Nobody cared about it 8 years ago because they thought, oh, 2018 will never come. But in the year 2018, if an employer offers a benefit that's so valuable, like say it's worth more than $10,000 of an employee, the amount over that, the employer has to pay 40% as a penalty to the federal government, 40% of the value over that amount. And that's kind of ludicrous. And that is the cited reason for the Alina strike. Do you guys remember the Alina strike a few months ago? Alina was on strike, and the employer was like, you're asking for a benefit that would subject us to this Cadillac tax, and I don't want to spend 40% more on getting nothing. So that was their point. So this is creating a lot of like union, this is creating a lot of like union controversy, a lot of strikes. This is going to hit it. And you could see maybe the Trump administration might back off on it because it's never been a very popular provision, right? And it doesn't even adjust for locations. So it doesn't adjust for like, if you're living in New York City, things cost a lot more than if you're living in South Dakota, right? They also gave $5 billion to have these people keep going with their retiree programs. And that money went within like 2 years. So they gave $5 billion to employers to say, keep your employer retiree program in place, your early retiree program in place. For fully insured large employers, it did the same thing. And it also said the insurer can't make more than too much of a profit. And so there's this, in almost every short-term insurance, there's this concept of a loss ratio. And it's the division of claims divided by premiums. So if you take claims divided by premiums and you got less than 85, say you got 80, they would say, you made 5% too much money, give the 5% back to the employers. Does that make sense? So it passed that provision. So if the insurer makes too much money, they have to give it back. Okay. To the pool, not to any particular employer, but to every employer. All right. Small employers, it did a lot of things. So it got rid of that 25% positive and negative, and it put everybody as equal. So some small employers who seem to be very quiet, they don't say anything at the legislature, saved a lot of money, especially the ones that had sick employees. And some small employers got a huge rate increase because they all of a sudden had like a 25%, even more rate increase. It limited, the Affordable Care Act limited how they rate small employers to only age of each employee and their dependents, rating area, the network they're using, the plan design they're selling, and tobacco. So they couldn't rate on industry, they couldn't rate on health experience, they couldn't rate on anything else. Nobody, in the small employer market, nobody really uses the tobacco factor because it's just such an administrative burden to figure out which employees smoke and which ones don't. And it also established an exchange, which we call SHOP. So people can buy small employer plans on the exchange. It established a minimum loss ratio of 80%. So if they have to give, an insurer would have to give rebates back to the whole pool of small employers if they made too much money. It established a very set level of coverages, which we call the essential health benefits set. All right. And all the provisions I talked about on large group basically apply on small group too. All right, so let's talk about, before we get into the individual market where all the explosions happen, let's just talk about two concepts I said. One concept I said was they could only rate on like metal level designs, and so there's 4 kind of metal levels: bronze, silver, gold, and platinum. And this is called an actuarial value target. And so they gave us this tool. I'll show you what the tool looks like. The tool looks like that. They gave us a tool where we fill in like the deductible and the coinsurance and the out-of-pocket max, and everybody around the nation is using the same tool to figure out how much actuarial value the plan has. You fill in co-pays, and then you hit the calculate button, and it spits out an actuarial value, and that's how you figure out, are you offering a bronze plan, a silver plan, a gold plan, or a platinum plan? Should I say anything else about that? Here's a sample plan design. This is what it works out to. This is what it looks like. If you have a platinum plan, you might have like a deductible of $650 with an out-of-pocket max, like that's when you stop having to pay, at $1,000, and you might have a coinsurance of 20%. It's a very nice, generous plan. That's kind of typical of what you get at an employer. Gold is very typical of what you have at an employer. And then the bronze plans, let's go there. That's like the cheapest plan that can be sold. And it has, it tends to have about a deductible and an out-of-pocket max of almost $7,000. So if somebody's buying a bronze plan, they are eating a lot of costs before the insurance actually pays for something. Does that make sense? It's a lot of money. Okay. So the other concept we talked about was comprehensive benefits. So I mentioned that essential health benefits. So the federal government set up this idea that everybody should have comprehensive major medical coverage. Well, what is the coverage supposed to have? This is a fancy word, ambulatory patient services. That's a fancy word for you could go to the doctor. You could walk in. I don't know why they call it that, ambulatory. Like you could walk in and go to the doctor. You got to have emergency room services and ambulance. You've got to have a hospitalization. You got to have maternity and newborn care. You have to have mental health and substance abuse coverage. You have to have prescription drug coverage. You have to have rehab and habilitative services. That's like speech therapy, occupational therapy, physical therapy, lab services, right? That's kind of obvious. Preventive and wellness services, so immunizations and shots and mammograms and colonoscopies and things like that. Contraception. And then you have to have dental and vision pediatric services. All right. So, step back. So what happened with the Affordable Care Act? What was the point of the Affordable Care Act? Is that everybody had like good coverage. and that it was really to address how many uninsured people there are throughout the country, right? That was the big point. So what happened in Minnesota is you could see that by 2015, our uninsured rate did go down. Even though we had been doing these efforts on our own to get the uninsured rate down, we had a really good, this was much better than most other states to begin with. We're usually in the top 5 of the 50 states of the lowest, even now with the uninsured rate. So these are really good. But you could see that, we basically halved the uninsured population in Minnesota because of the Medicaid expansion, because of the individual market opening up. So let's go to the next slide. We're going to start talking now about 2 subsets that are creating most of the media that you hear. It's the individual market. I'm going to throw in Minnesota Care there for a second, just because Minnesota Care makes us a little unique. We have about 100,000 Minnesotans who normally would be in the individual market getting a really big federal subsidy, but instead they're not their own risk pool. They're not in the individual market, and they're getting Medicaid-like benefits, and we're very unique in that. So that's my only mention, pretty much, of Minnesota Care. But in the individual market, it had all of those small group reforms, comprehensive benefits, but all of them mattered more because before 2014, it was hard to get for an individual, even an individual that was healthy, to get comprehensive benefits. So I'm going to step back for a second and just explain which ones typically weren't covered. So typically, maternity and newborn was like a rider that you might add on, and they charged you a lot if you needed it, because half the population might need it, and then by age it's even less than that. So they charged a lot for if you wanted to add on a maternity rider. So you were kind of in a risk pool of yourself, of people that were more likely to need maternity care. Mental health and substance abuse was also a separate benefit, and of course you're more likely to buy that benefit if you needed it, so it was very expensive. Prescription drugs was usually a separate benefit. Dental and pediatric vision wasn't there at all. Prevention wasn't usually 100% covered. Usually the typical, when I worked at Blue Cross, half the people preferred a $10,000 deductible plan because it's all their money. And when it's all your money, and you're really just saying, oh, I just want to have insurance for the worst case scenario, you do, because every penny of it's gone. You pay an insurance premium and it's gone. It's money that's gone. So it's different in the employer market because the employer gives about 80%, typically 80% of the premium the employer's paying for. And so it becomes a heck of a lot more valuable to you to buy health insurance when you're at an employer than when you have to pay that whole price yourself. All right, so every single reform mattered more in the individual market. In fact, the small group market didn't change all that much because the whole benchmark was set on the small group market, and carriers were very competitive. They didn't want to lose small employers to their competitor because they weren't offering hospitalization or pharmacy or something that's so obviously needed. The other thing that changed dramatically in the individual market was guarantee availability. And so basically, there was no more rejecting anybody. Basically, if you're a Minnesotan, you could buy individual health insurance. Nobody could be rejected on health. And so that is causing the rates to go up a lot. So many people rejected. Plans had $10,000 deductibles. Before the Affordable Care Act, if you got rejected, you just had to kind of show your rejection sheet and say, look, I got rejected from health insurance. And we had an entity called MSHA, which is the Minnesota Comprehensive Health Association, and they would sell you, they had to take you. And we had this pool of subsidy for all the other markets, the fully insured market, the small group market, the individual market. All the carriers had to pay based on their premiums. They had to pay about 3% of their premiums over to MSHA to fund MSHA. And so MSHA got like half of the money it needed from all the other markets. And it was about $180 million. It's a lot of money. When the Affordable Care Act came, there was no need for a high-risk pool anymore, but we also didn't have that financial support coming from the other markets. So instantly, we lost a lot of money, and the rates had to make up for it. Does that make sense? Okay. All right, so here's what happened to the individual market. And this is the market that in a lot of states is causing a lot of media about the rate increases. So we had about 225,000 people in the individual market, and then all of a sudden it jumped up. It hit a high point in March of 2015 of about 300,000 Minnesotans, and then it's been on a decline ever since. And if I was to draw that line out further, you know, it would be on a pretty steep decline because the rates every year get announced in January, and they go up quite a bit. So I'm not crazy about this chart because I have the scale. And one of the rules is being an actuary is you're supposed to like watch the scale of your charts, and I realize that. But when I create these charts, I have to create them with, sometimes they go up to 1,000 per person. So, so what you could see here is in 2014, this actually is a view of the bronze rates, the silver rates in green, the gold rates in red, and the blue diamonds are the platinum rates. So if you kind of follow this, this is 2014. Each of the lines is a different carrier. And you can see that they're pretty competitive. They're near each other. So from 2014 to 2015, you can see there's a general rate increase. This is all a person age 40. But by the time you get to 2017, and because of my scale, you're not seeing this, so I'm going to point out a few just so, you know, the lowest priced platinum rate right here was somewhere around $120. Bronze. So like, what's the cheapest you could buy? Bronze. And now, you know, the lowest is about $250. So it's a lot. So people's rates have gone up almost double. I could tell you personally, I bought on the individual market in 2014, and it cost me about $500 a month for my family to have the bronze plan. And I bought the cheapest plan I could possibly buy. So I was paying $6,000 a year for a deductible that was $13,000. So it wouldn't even pay for anything until I put in $19,000, right? That same plan right now is 3 times as much. So they'd ask me to spend $29,000 before it paid a dime in the insurance. Because what I could buy right now would be something like $1,500 a month for a plan that has like a $7,000 deductible. So anyway, it's a lot of money. And so what's going on, this is the Twin Cities. Sorry about that. This is the same exact chart, but for Rochester, Minnesota. And what happens is if you happen to live near the Mayo Clinic, things are even worse. It's about 30% higher because the Mayo Clinic charges so much for each visit, a lot more. And so the Mayo Clinic people, the people living around Rochester, are suffering and have always been suffering much more than everybody else. Okay, so here's a view of like who pays different rates. They kind of we took our state and we had to do like a view of like statistical homogeneousness of the rates. And we had to like make it contiguous counties. So we had to make sure that we created rate areas where the premiums were kind of consistent and the costs were consistent. And so you could see, like, if you live here, the rates are 30% higher than if you lived right here. And if you live up there near Duluth, it's still not very good. Because what happens in the health system is, in the rural areas, there's not a lot of provider competition. And the doctors can kind of charge what they want. Because there's nobody competing with them for patients. So you hear a lot in Minnesota about Mayo Clinic and how great it is, but and it is great. It's wonderful to have a world-class clinic, but there's some negatives that go with it too. If you happen to be paying 100% of your health insurance and you're paying 30% more than everybody else. All right. So not everybody pays the full freight of their premium, though. The Affordable Care Act created a couple subsidies, the biggest one being this premium subsidy that's based on income. So this is a view of 2017. Right here on the y-axis, I've got the percent of income you're being asked to spend on insurance, health insurance, on the individual market. And right here, I got annual income. This is just for one person. So and then right here, these lines right here are somebody who's age 60, somebody who's age 50, somebody who's age 40, somebody who's age 25. And the way the federal subsidies work is if you have an income where the federal below 400% of the federal poverty level, you get a subsidy. And the subsidy is graded, but it's based on your income, and it pays, this federal subsidy will pay for everything over that percentage of income, basically. So everything here above the curve is being paid by the federal government. But you could see what happens to the 60-year-old who happens to make $50,000 instead of $46,000. And this, by the way, happens to be a lot of Minnesota's farmers. You know what I mean? It's just like they're being asked to pay a lot of money. It gets even worse if you live in Rochester, near the Mayo Clinic. Okay. And there's a lot of farms around there. All right. So what you might say, well, what's going on? Why are rates going up so much? It must be because there's not enough young people buying the health insurance. And it's true that if you look from 2014 to 2016, the pool is getting a lot older. So if you look at this, when we collect the data, we estimate that in 2 years, the pool aged 3 years. Now, a good risk pool should stay stable, like the age should stay constant or pretty constant. It should only be, a good pool would only age by the aging of the population, like the thing you hear about, like, oh, the baby boomers. That could happen. But basically, in 2 years, the pool aged 3 years. Now, you and I, last year, were probably 1 year younger, right? So, right, you expect. So it's not only that, like, the same people are there, but a lot of people left that are young. And that's true. But, like, if you look at how we grade the premiums, so we have this age curve, and the age curve that we use, they charge more premium to the older people. So the age curve is right here. It's the smooth line. It's kind of pink. And then if you look at, like, the green line, that's the individual market experience. And if you look at this line down here, this is the small group market experience. They both use the same age curve. You see that our experience actually kind of lines up with the age curve pretty closely. I mean, I wouldn't say it's perfect, but it's pretty good. So it's not necessarily that the pool needs younger people. It just needs healthier people at every age. It needs a lot healthier people. All right. Now, another idea, and this is something that Trump is saying is, well, I know what we need to do. We need more people to buy HSA plans. An HSA plan is a really great idea if you're an individual market person because HSA is a health savings account. And it's kind of like a 401k. It's like you agree to buy a high deductible health plan, and then you could put your money, and you don't get taxed on it. So it's just like a 401k. It's like you didn't make the money. So you could put like $3,000 over to an HSA, and it's like you didn't make that $3,000. And if you withdraw the HSA for health claims in the future, it never gets taxed, it's really great because there's very little income that you could ever make that never gets taxed. An HSA you can actually have an income stream that never gets taxed. Well, if you're an individual market person, that's ideal, right? Because it's your money, right? You're either going to pay it in premiums or you're going to be paying it in like what you have as a deductible. So you might as well save the money in an account for a rainy day, get it tax deferred, and keep it there for when something happens. But the problem is that's what these plans tend to be anyway. So these bronze plans and these silver plans are HSA plans. So the people are doing that. So it's not really a solution because they're already doing that. It's already available. It's already very, very popular. So if you look at what Minnesotans are selecting is, as the rates got higher and higher, they have moved in droves to the bronze and the silver plans. So 75% of the people are already in a really, really high deductible plan, probably have an HSA already. Okay. Sorry about that. I'm going the wrong way. And they're buying these plans regardless of age. So we collected data on like, well, are the children having silver and bronze? Is it old people that are getting the platinum? And they're buying bronze and silver at every single age span. Does that make sense? Okay. So the problem of what's going on has to do with the high claims people. So what we did was we collected data, and this down here is how you'd bracket like somebody's claim. So if I hit the $1 million mark, I'd fit right here. And right here is all the money in the individual market. So if you look at the area under the curve, right, you see that about 50% of the area of the curve is right here. Well, this is, right here, is a $48,000 a claim person, like one person that cost $48,000 or more. That's 2.2% of the population causing 50% of the claims. That's our problem. That's the problem of the country with these individual market rates. Now, a good question you would ask is, well, is that what it's supposed to look like, right? Like, this is actually a pretty typical curve for an employer, too. This is where healthcare is spent. It's spent a lot on high case claims. Does that make sense? So this is not atypical. The problem in the individual market is, though, that because it doesn't have the kind of support like an 80% subsidy like an employer gives you, it's on a trajectory to get worse and worse every year, because if you're sitting here, where most of the people are, you're wondering, why am I spending $20,000 a year for nothing, right? And they're dropping out in droves. And the health insurers are saying, I got to raise my rates again another 30%, which the very next year turns around and these people say, why am I buying it? So it's a huge social issue. It's a huge problem to solve. All right. So the workable solutions need to address this issue, and you're not going to address this issue with a health savings account. You're not going to address $48,000 or more with a health savings account. And the problem is the burden for a lot of people who find themselves in like situations like cancer, a lot of cancer claims. It's a lot of cancer here in that bucket. It's a lot of, it's like a third cancer right there. So if you're in that life situation where you have cancer, do you really want to be on your employer plan anymore? My neighbor was diagnosed with a really serious disease. We thought we were going to lose her. And she's like, Kristi, I would like you to help me buy individual health insurance. And of course I'm like, yeah. Because if you're facing like a life-threatening illness, you're not thinking about your job anymore, right? You're thinking about like getting better, being with your family. And the individual market's perfect for that. But the problem is the burden of those people. We used to have $180 million of support, and that's a lot of support. But the burden is on these really healthy entrepreneurs and small family farms and daycare providers, and they can't afford to have the whole burden of that on them. It's already hard enough. Their own costs are already hard enough to afford. So what happened this year that was really tough on us was Blue Cross Blue Shield of Minnesota, which was my past employer, they said, look, we lost $500 million in the first 3 years of the Affordable Care Act in the individual market. we're calling it quits because we don't have, like, it's not money that makes money. I mean, it's gone, right? We can't get in front, you can't price in front of it. Actuarially, we call it like a death spiral because you can't get in front of it. You can't price it because the second you price it, a whole bunch of more people leave that were healthy. So you just can't get in front of it. And they said, we don't think we could get in front of it unless we create different provider relationships where the providers take on some of this risk. And so they left, and that caused a huge problem for us because they were covering about half the people in the pool. So half the people in the pool had to find a new insurer. And some of them haven't bothered to look at all. So half of the, a lot of people are going to go uninsured because it's just unaffordable. So what's the solutions? Should I stop there? I'm going to stop there and take a question or two. Anybody want to ask a question before I go to solutions? Like what's out there for solutions?
Well, I guess were you surprised by the recent comments that Trump basically said, oh, healthcare is complicated, I don't know how we're going to fix it?
So my boss was like, send me this text, right? And he wrote, you should have warned us, Kristi.
I just don't, I guess personally I don't get why you say something like that.
Every state has pretty much the same story. I mean, I listen to Tennessee and I listen, we all have like the same story of these rates are going up, they need money. The problem is it needs more money to fix it. And it already put a ton of money in it. And is the Trump administration going to put more money in it? So I laughed. So it's like, yeah, it's complicated, right? Like if it was easy to fix, it would have been fixed, right? So that's always the problem of the biggest social issues. If it was easy to fix, it would have been fixed. Like we're not sitting around lazy, right? So good question. But yes, I was like, we kind of laughed at work, like, yeah, it's complicated. So, all right. So I'm going to talk a little bit about Minnesota and what, it's a really great state, and we care, So there's been a lot of bipartisan support to make the market more affordable. The Republicans and Democrats alike in our state. In fact, the Republicans in this state, in the state legislature, have done a really excellent job and put forward a lot of the bills that would address this problem. So it's both parties are trying to come up with good ideas, and they're on both sides of the aisle, really good ideas. Minnesota's a little unique because of our basic health plan, because we took 100,000 people out of the pool, and having those 100,000 stable people in the pool would have been helpful to the pool. But at the same time, those people are getting great benefits it's really affordable. And to take that away would also create its own issues for our state. We're also unique in that we have a unique age curve. So a lot of the other actuaries didn't, I would say even our actuaries care. So like, when I'm gonna go back to this age curve. One sec. Okay, so when the Affordable Care Act regulators, the federal regulators, announced this is the 0 to 20 bracket right here. When they announced the factor, they put it at 0.635 right here. And we were like, what? So we put ours right there. This is where the experience came in. But we put ours quite a bit higher than other states. That's a 20-year bracket. So that really, this chart should be going out like way out over here. So, but all of our carriers' actuaries said 0.635 is actuarially insufficient, and we're the only state that figured that out. And we figured out like within 3 or 4 days, they were calling the regulators saying you got to have applied for a unique age curve because they got it wrong. And still, you hear all this stuff around the country about, oh, I know the problem. The problem is the 3 to 1 age curve. You just have to make it a 5 to 1 age curve. That's actually appropriate. And they're wrong. They didn't collect the data. They're not taking into account that this 20-year age bracket was mispriced. It's not even currently priced right. So what it means, they keep saying, look, it's the young people have to subsidize the old people, when it's actually the exact opposite. The old people in other states are subsidizing the young people. However, the federal government's giving most of the money to the older people, right? The federal government's sending most of the premium over to the older people.
I had a question about, you had those pie charts of like age ranges of
Sure.
and the 22 to 29-year-old.
Yeah, so they have this blue, that's a great question. So there's this blue bucket there. That's a catastrophic plan. It looks very much like a bronze plan. It's only available to those under age 30. It looks, and its value is like a bronze plan. They sell it a bit cheaper, but you have to be under 30 to get it. And so those are bronze plan-like people, and that's why it's so different. Great catch. Yeah, so the catastrophic plans, that's another thing that's out there, is like this idea, well, like, let's make it catastrophic plans. Well, the catastrophic plan's value is just like the bronze plan. It's even a little bit more valuable because they give you 3 physician visits for free. So it's a very high deductible, like $7,000 deductible. Good catch. Any other questions? Let me check the time. All right, 6:21. I have 9 minutes. Wow. All right, so, all right. We also are really unique in Minnesota because we have really large competitive health systems, especially in the Twin Cities. So we're really unique in this. I didn't appreciate this, but I grew up in New York, and I never really appreciated that. Yeah, it was like in New York, there's doctor, little small group of doctors, little small group of doctors. In Minnesota, it's like Allina, Health East, Health Partners, Fairview, Mayo, St. Luke's. Am I missing any of them? We have very competitive, very big health systems who negotiate, but they're very competitive. And so they work very hard. In the Twin Cities, it's very competitive, so it's helped keep the rates lower because they're so large and they can negotiate, but at the same time, they can innovate and make things more efficient. So we're very unique. A lot of states, that's unheard of. We're also unique in that we have highly sought-after world-class providers. So people come from all over the world to go to Rochester to go to the Mayo Health System. It's very unique. I mean, there's the Cleveland Clinics and there's Johns Hopkins, but it's a pretty unique situation. It's in a rural neighborhood. All right, so what's going on at the state? On January 26th, the very first bill so our session began on like January 3rd. Am I right, Sherry? Yeah. So our session began on January 3rd, and right away, the very first bill was about the individual market. And the governor had announced ahead of time that he was willing to give a bit more than $300 million to support a voucher for those that don't have the federal support. And at first, there was a little bit of like, well, let's get a little complicated on making this administratively complicated, but it passed. It was entered, so they named bills like the number it comes in. So SF1 means it was the very first bill. HF1 and SF1 at the House and the Senate and the state. It passed, and so they passed this subsidy that's going to give like a 25% rebate to anybody that didn't get a federal subsidy. So it's pretty great when you think about it. Like, okay, here's this health insurance plan. The governor could do that because he had a $1 billion surplus. It's not very often that we're in a surplus situation, okay? They also passed a bill to make it easier for farmers to get together and form their own risk pools so that farmers don't have to go buy at the individual market. They could create their own risk pool amongst themselves. They also broadened self-insurance stop-loss solutions for small employers. And they also think that allowing for-profit HMOs to exist will help solve the problem. I put a little article, this is from the weekend, about that part of the bill, where it's kind of skeptical, and I'm a little skeptical. I'm not speaking for the state, I'm speaking for myself. I'm a little skeptical that that for-profits are interested. Because when you think about the individual market, it's lost a lot of money. And if you're a for-profit, you have to kind of pay shareholders in the end. And you're going to go into more profitable, less risky situations. And so it was passed to allow for-profit HMOs, but I'm not convinced that will do anything to help the individual market. 2018 and beyond, it's being discussed today. Today we've been working on this issue. So at the state legislature, there's 2 or 3 solutions being discussed today to make 2018 and beyond's individual market more affordable. It's pretty current. On the federal side, their solutions have to kind of reach nationally. So they're talking about modernizing Medicaid. So they're thinking of doing block grants. And the problem with block grants are this idea of let's give you a bucket of money and you state can go do what you want with it, but it's like for Medicaid. The problem with that as Minnesota is we've always done more than every other state. So we've done more, we've paid more as a percent than other states too. We're on the lower end of what we pay as a proportion. And we're a smaller state. So what happens with block grants is forget about red state, blue state, it becomes small state, large state. Because Florida and Texas and New York and California are going to have a lot of people. And they're going to say, give me more of the pie. And so you're going to see the argument go from blue to red to big to small. And we're not that big, right? So we'll be on the small side, and we've already started from a place where we're spending more than other states. So it really puts our state at risk. They want to use innovation grants, and we're a fan of that. We're a fan of the federal government letting us do our solution, but giving us, letting us do our unique solutions, like getting rid of these stupid cliffs, right? Like spread this money out to more people. We're a fan of that, but like we want the money to still be there at the same level that it is. Like we don't want them to take away money overall to help this problem because the problem needs more money. They also want to enhance health savings accounts and we're a fan of this. It's basically like letting people put more money away into health savings accounts. Instead of putting $3,000, why can't they put away $6,000 a year? It's great because it's not our money, it's their money, and really, like, we're a fan of that. And they want to provide portable monthly tax credits. And this is an odd one. And, truly, I think tax policy is really odd. So if you're an employer and you're spending your employee and their family's health insurance, you get to write that off as a business expense. But if you're self-employed, it's not tax exempt. There's very little of your health insurance premium that's tax exempt, and that's not fair. So the idea of changing tax policy, perhaps doing tax credits to correct tax exemption differences, we're kind of a fan of. When I say we, I mean me and maybe a few other actuaries I work with. I'm not speaking for the state. But that's what's being talked about right now. This is a administration brief that came out last week, so it's pretty current. And that's the end of my presentation. So I think I ended with 2 minutes to go, so I could take one more question. Okay, or 2 more questions.
So the unemployment, or not unemployment, but uninsured have gone down by half. Yet the small market, the healthy people are also leaving. So where are they all going?
Okay, so the question was for the recording. So the question was, okay, if these uninsured are going, where are they going? So the data I showed you, where is it? The data I showed you on the uninsured was in 2015. I suspect that this is going to creep back up. And where are they going? We don't know. So what we do, this is a pretty good, for some of you who might be looking for a job, the Department of Health Economics program, they do a lot of statistics. They gather a lot of data. They do a lot of fun statistics. They also do a survey every 2 years where they actually like call people up and say, where do you get your health insurance from? And so it's kind of an interesting survey that they do. And they try to figure out like where they are. But they never try to, they don't, it's hard to do like correctly. Like people don't really know, oh, I had this and then I had that and then I had, like even a Medicaid person says, well, I don't have Medicaid, I have like Blue Cross, because that's what it says on the card, right? Like that's the way most of us think. So my guess is, and these people that do the survey would be really sad that this is my guess, but my guess is this is going to creep back up even for Minnesota. Where are they going? I wish I knew. Some of them are going back to small employer insurance. Like if they're small, but they had an employee, if there's two of them, if they're their small job, they could go to the small employer market and justify buying on the small employer market, which is about 25-30% less costly. And so that's what a lot of them are doing. Probably if you're your spouse, you're probably going on your spouse's plan, or you're making somebody in your family look for a job. That's a lot of the stories that we're hearing. Some of them are going to go uninsured.
Yeah, so I wonder for the individual market insured goes up. So I wonder why the federal government saying that the rating cannot depend on the health condition. Whether
So the question is, why don't they just limit the rates? Well, every carrier would leave. Because like if we had said, hey, you can only increase your rates to 10%, they all would have left because they're not in a business to lose money. And we actually, as regulators, are not supposed to approve of inadequate rates. Reason is because we care just as much that your claim gets paid in the end. We don't want the insurers going bankrupt. So in the end, we have to care that they actually pay your claim too. So when Blue Cross lost $500 million, like it's hard to put that in perspective, but the question is, well, how much money did they have to lose? Well, they lost about half the money that they could lose. Like they don't have, it's not so we need to make sure that these companies stay in business. And in fact, if they don't have enough capital, then we have to start taking over and becoming, like as a regulator, we have to kind of assert ourselves as helping to run the company. And that's what we try to avoid. We try to let these companies compete and not be run by the government,
How much of the Affordable Care Act do you think will stay in place in the next 4 years?
I think the Trump administration has figured out that the reason why they can't just switch it is because the carriers can't exit without everybody losing their health insurance. Like you can't just start all over, right? So the sick people are there, and the only way the carrier can not have them is to leave. And so I think they figured out, like Trump met with a lot of the major national health insurers in the last few days, and I think he got the message like, oh, I can't fix this overnight because the carriers need to be there,
I
right?
think he's gonna like cut back on some of the things.
He seems to say that the things he's going to keep are the age 26. So you guys should all say, yay, right? Like age 26, which is the most popular, most loved Affordable Care Act change that people don't necessarily connect with the Affordable Care Act. He's going to keep like the age 26, and he says, well, and I'm going to keep the pre-existing conditions. Well, that's a lot of like the reason why we're here. So like he's trying to keep the core parts that are costing the money, right? And he seems to not get that like these people the sick people have just as much right as the healthy people to continue on and have their policy renewed. So the only way that the carrier can get out of not covering them is to leave. And they've all said, well, we're going to leave. So in our state, we're saying, let's get them to stay, and we have to realize that the problem is here, and this problem shouldn't be borne by these people only. Some of it, yeah, but like society needs to kind of grapple with this issue also. And in our state, we recognize that we had a $180 million fund that used to exist, and that's more than half. It's probably like 60, probably like 80% of what we need. Like the money that we used to have is kind of the money we need to get the kind of financial support for these people. So Trump has said that he's not going to enforce that penalty. So like so when they make IRS forms, it's a long year, 2-3 year process apparently, but he's instructed the IRS not to enforce the penalty. But truly the way the penalty works is you look at the lowest price available out there. So look at your cheapest bronze plan. If that plan is more than 8% of your income, you're exempt. And there's a little form to fill out. So there was this article in the Wall Street Journal about this lumberjack, and he was like 50 years old, and he said, in Alaska, it's the worst. Their insurance costs like 3 times what our insurance costs. And he said, I'm going to have to take the penalty. And so I wrote to the Wall Street Journal, and I said, unless that lumberjack is making $182,000 a year, he doesn't have to pay the penalty. And if he's making $182,000 a year, I think I'm moving to Alaska and becoming a lumberjack, right? Right? And he was. So a lot of people are actually exempt from the penalty, and they just might not know it. Nobody's advertising that they're actually exempt.
Isn't the penalty cheaper than the insurance, right?
Yeah, the penalty is about it's 1% of income up to, or a minimum of 1,000 something.
Did that go up next?
It gets indexed, but it's probably around 2,000. But most people are exempt because most people, like the bronze plan is more than 8%. The cheapest bronze plan is more than 8% of their income. So most people could fill out that IRS form and be exempt. And they're not enforcing it this year. You're welcome. Any other questions? All right, well, thank you for your patience. And